Okay, I think we are now live. I am Denis Fouque from Lyon. I'm very pleased to introduce this first ERA DTI Working Group's e-seminar, which is entitled the new KDOQI Clinical Practice Guideline for Renal Nutrition in CKD. This webinar is organized by the European Renal Nutrition Working Group, which has been funded around five years ago and is now chaired by Professor Juan Carrero from Sweden. Today we are enjoying a very nice topic on the new KDOQI guidelines. We will have one speaker and three panelists. The speaker is Professor Cuppari from São Paulo, Brazil. She belongs to the KDOQI formation. And we also have a panelist with Professor Avesani in Stockholm, with Professor Carrero also in Stockholm, both in the Karolinska Institutet, and Professor Bellizzi from Salerno, Italy. So first a lecture of about 30 minutes, which we start now, followed by 30 minutes question and answer. Thank you for being here, and I wish you a nice session.
Okay. So I'll start with this brief overview in the guideline development. It took almost 6 years to be completed. And here are the main steps in conducting the evidence-based clinical guideline. The first step was to define the scope, which is in this guideline is adults with CKD 1 to 5D plus transplanted patients, and then develop the questions. The literature was gathered and classified the research. Then the next step was to critically appraise each article. This was developed mainly by the group or the team of the Academy of Nutrition. Then the data was summarized, the evidence was summarized in an overview table and the evidence summary. And the next step was to develop the conclusion statement and grade the strength of the supporting evidence. Each statement was assigned a separate grade for evidence quality. So as you can see, from A, high quality, to D, very low. And then the strength of recommendation, level 1, it was used, we recommend, and level 2, we suggest. This decision was made by the guideline work group. After that, the manuscript was drafted and then submitted to peer review, an internal peer review and external by a group of experts of the International Society of Renal Nutrition and Metabolism. Then it was submitted to public review. And finally, it was published and disseminated after 5 to 6 to 5 years of completion. And this is where we are. And we hope in the future there will be updating and the guideline should be revised. The guideline has comprised 71 recommendations divided in 6 guidelines. Each guideline includes a statement, a topic of rationale and background, a special discussion, implementation consideration, and future research. And I invite you, and I strongly recommend you not to read only the statement, but all the other topics. It's important to interpret the statement. Let's start with the nutritional assessment, guideline 1. Regarding routine nutrition screening, there is limited evidence to suggest the use of one tool over others for identifying patients at risk of protein energy wasting. There are a number of methods, but it's important to consider involuntary weight loss, insufficient dietary intake, and lack of appetite. Here is the suggestion for frequency assessment biannually to identify those patients at risk. And when a patient is identified, it is recommended a comprehensive nutritional assessment, history with these topics, history of dietary intake, anthropometric and body composition measurements, nutrition-related physical examination, and biochemical data. It is suggested that the assessment should be performed within the first 90 days of starting dialysis and annually, or when indicated by nutritional screening or referral. Regarding anthropometric and body composition measurements, body weight, although very simple, it's challenging in CKD, and there is no consensus of how should be measured. And so it's important to base in clinical judgment, and especially focuses on changes of body weight. Obviously, it should be considered hydration status changes. Regarding BMI, BMI alone is not sufficient to establish a diagnosis of protein energy wasting unless very low, but low BMI is a strong predictor of mortality. And as limitations, there are no studies examining the validity or reliability of using BMI to classify nutritional status. Skin fold thickness is recommended for assessing body fat in the absence of edema, with a high level of evidence due to the accurate, to the studies showing this method is accurate when compared to DEXA, but the accuracy may be limited in obese patients, so be careful with these patients. Waist circumference is a wide method used to assess abdominal obesity, so it's suggested to be used in CKD. However, low reliability in assessing changes over time, and cutoffs are unknown. Regarding technical device, hand grip strength is suggested as an indicator of protein energy wasting and functional status, mainly related to muscle mass. It's important to have longitudinal measurements. Cutoffs are unknown, and it's also unknown that the best time of measurement is pre or post hemodialysis, and consider diabetic patients with peripheric neuropathy. Bioelectrical impedance is suggested in patients on hemodialysis to assess body composition, preferably the device, the multi-frequency device, and after 30 minutes after the dialysis session is finished, to allow the distribution of body water. In non-dialysis and PD patients, there is insufficient evidence to recommend or to suggest bioelectrical impedance. Here are the suggested frequency for assessment of body composition. It's according, depending on the stage of the disease, at least annually or at least monthly in patients on PD or HEMO and PD. Composite nutritional indices, 7-point subjective global assessment. It's recommended as a valid and reliable tool for assessing nutritional status in dialysis with a high level of evidence. And the malnutrition inflammation score is suggested to also to assess nutritional status in HEMO and post-transplantation and post-transplanted patients. We have to have in mind that there are, because of the subjective nature of these indices, limitation for identifying slight changes, and there are no studies evaluating validity and reliability in earlier stages of CKD, and MIS cutoffs are unknown. Regarding biochemical measurements, biomarkers, it is suggested to use NPCR, serum albumin, or prealbumin. And here is important, are complementary tools and should not be interpreted in isolation, because as you all know, there are many other factors that can influence these markers, such as hydration status, inflammation, protein loss. And serum albumin, on the other hand, the lower values are predictor of hospitalization and mortality. It's not clear which is the best cutoff point. And last but not least, dietary assessment is an important step of nutrition assessment. It is suggested 3-day food records, but other methods should also be applied. But this is very important, this suggestion here, that it's reasonable to assess factors beyond dietary intake, such as knowledge, beliefs, attitudes, behavior, access to food, psychological condition, to effectively plan nutrition intervention. So in summary, in this guideline, it's clear that nutrition assessment in CKD is quite challenging. No method is perfect. Limitation and error should be considered. Combination of measurements is recommended to improve reliability, and longitudinal measures are recommended. Medical nutrition therapy, acknowledge dietitians in collaboration with other health providers to provide medical nutrition therapy. The goals are to optimize nutritional status, minimize risk imposed by comorbidity, and alterations in metabolism and the progression of kidney disease. It's important to highlight that MNT should be tailored to individuals' needs and should be monitored to assess effectiveness. Regarding energy and protein intake, as you can see here, there was an expansion of the energy recommendation compared with the previous guideline, 25 to 35 kilocalories per kilogram per body per day. But it's important to analyze other factors, are important factors that can influence energy needs, such as demographic, body composition, and the presence of inflammation to maintain nutritional status. Protein intake in dialysis has not changed substantially in comparison to the previous guideline, 1 to 1.2 grams per kilogram body weight per day to maintain a stable nutritional status. Protein intake, not in dialysis, in my view, there was an improvement in this recommendation because there are in the last 20 decades a number of studies with what was possible to evidence that protein restriction with or without keto analogs can reduce the risk of end-stage renal disease or death and improve quality of life. It's recommended a low protein diet of 0.5 to 0.6, and when a very low protein diet around 0.3 to 0.4, but supplemented with keto acid analogs to meet protein requirement. And this recommendation is for non-diabetic patients without diabetes who are metabolic stable. And for those with diabetes, a less modest restriction, 0.6 to 0.8, in order to optimize glycemic control. So some implementation considerations. It's important when we think about protein restriction to increase healthcare providers' knowledge and to increase training and the number of specialized renal dietitians. Energy intake should be carefully monitored with special attention with protein restricted diets. Low protein diet should be implemented gradually. This is very important to allow careful dietary counseling and to improve adherence. And adherence to the diet should be monitored frequently. Guideline 4 describes nutritional supplementation. There are 4 new statements to acknowledge each of the nutrition intervention opportunity to supply protein energy to adults at risk or with protein energy wasting. So the natural progression is nutritional counseling at first step. Then if it not improve, it should be associated with oral nutritional supplement, then enteral tube feeding, and for patients on hemodialysis, intradialytic parenteral nutrition or total parenteral nutrition. Micronutrients was indeed challenging to establish recommendation, even though it was found 80 controlled trials, but there was a paucity of good quality evidence to either support or oppose routine supplementation of micronutrients. In many intervention studies, baseline status of micronutrient levels was not known, and participants may not be deficient of the micronutrient. Duration was too short to evaluate hard outcomes, and most studies were with patients on hemodialysis with the sample size is too small. As a general guidance, it has been suggested to encourage patients eating a diet that meets the recommended dietary allowance for the general population. It's important to assess dietary vitamin intake periodically and maybe consider supplementation for those with inadequate vitamin intake. And consider supplementation with multivitamin to prevent or to treat micronutrient deficiency. Folic acid supplementation has not been recommended routinely for hyperhomocystinemia. No evidence for reduction in cardiovascular outcomes. And folic acid plus B12 supplementation only if deficiency is present. Vitamin D supplementation, it is suggested at least the RDA for the general population, and be careful with high doses because of the risk of oxalate accumulation. And vitamin D supplementation through cholecalciferol or ergocalciferol to correct deficiency, and it's suggested to follow supplementation protocol for the general population. Vitamin E and A supplementation is not indicated, potential risk of toxicity. Vitamin K supplementation, it's not indicated for patients receiving anticoagulant medicines, and zinc and selenium not indicate there is little evidence of benefits. Electrolytes, here are some general considerations. It's important to consider the source of electrolyte, if it's natural, organic, versus artificial, inorganic. It's important to highlight that food composition tables and dietary assessment methods cannot adequately capture electrolyte intake. In the guideline, as you see, there is no ranges of intake. It was not suggested. No recommendation is permanent, so it should adapt to periods of the disease. Patient education is better than generalized restriction, and generalized restrictions worth diet quality and diversity and deprives from other health nutrients. And we have to think that excessive restriction worsens adherence and may cause psychological and behavior distress to the patients. Acid-base balance, it is suggested to increase dietary intake of fruits and vegetables to reduce net acid production, and also to supplement bicarbonate, also to reduce the decline of residual renal function. And it's reasonable to maintain serum bicarbonate at 24 to 25 millimole per liter. Some considerations for implementation of dietary pattern richer in fruits and vegetables. Initially, add lower potassium fruits and vegetables to the diet to assess the impact on serum potassium levels. Adjust both type and quantity as needed based upon ongoing monitoring of potassium levels, especially in CKD stages 4 and 5. Investigate and whenever possible, treat other causes that may increase serum potassium levels. Investigate dietary sources of potassium other than fruits and vegetables, and monitor serum bicarbonate to assess the impact of medication and or dietary changes. Dietary phosphorus, as you can see, we recommend adjusting dietary phosphorus and also paying attention on the bioavailability of phosphorus sources. It's different, especially the absorption of phosphorus is quite different comparing animal, vegetables, and additives. So this is different from the previous guidelines that in this guideline, we did not provide a range of intake. So this is important to individualize treatment. I think one of the most important messages in this guideline is individualization. And as I mentioned before, it's important to take into account the bioavailability. Another concern regarding adjusting or restricting phosphorus is how to maintain adequate protein intake. So it's important to start assessing patients' usual food intake. This is an important and first step. Then to instruct patients on how to read food labels and phosphate food additives, limit soft drinks and convenient foods, prefer foods with lower phosphorus to protein ratio. For example, meats are lower, the ratio is lower than dairy products. Promote fresh and processed and home-cooked foods, and consider other aspects related to food intake, such as ability to prepare, and consider food habits and preferences. Dietary calcium for patients not on dialysis, CKD 3 to 4. It is suggested 800 to 1,000 milligrams per day, including all sources of calcium to maintain neutral calcium balance. And for patients on hemodialysis, is also reasonable to adjust calcium intake, considering all the sources. And remember that other compounds such as vitamin D analog and calcium mimetics can increase, can cause or hypercalcemia, so it should be avoided. Dietary potassium, it is again recommended to adjust and not to restrict. I like this word. To maintain serum potassium within the normal range. And again, it's different from previous guidelines. Again, individualized adjustments. And it's important so that excessive restriction of potassium through health foods may favor nutrient deficiency. Implementation considerations consider conditions and factors other than diet that may cause hyperkalemia, and there are a number of them. Assess dietary intake of foods other than fruits and vegetables that are also rich in potassium, such as dairy, meat, and highly processed foods. Provide patient information of fruits and vegetables with lower potassium content, and provide patient information of cooking procedures to decrease potassium content, mainly of vegetables. Dietary sodium, the recommendation is quite similar to the general population to reduce blood pressure and improve volume control, and also to have a synergistic action to decrease proteinuria. And it's important as an adjunctive lifestyle modification strategy to achieve better volume control and more desirable body weight. It's important to highlight that this level of sodium restriction, it's not very easy to obtain in real life. And finally, although there is low evidence still, but observational studies has shown that Mediterranean diet is suggested to improve lipid profiles and also increase fruits and vegetables. It is suggested to decrease body weight, blood pressure, and acid production. So this could be a change in paradigm. And my question is, should nutrition guidelines continue to be based in individual nutrients or on a whole diet approach? I think future research in this area is priority. There are some limitations to be acknowledged in the guidelines. Several statements are based on expert opinion due to the lack of studies. Many areas and patient populations are not covered: acute, obese, elderly, racial backgrounds, interventions such as exercise, but guideline updates are a continuous and dynamic process. And finally, it's important to acknowledge this great team that worked in the guideline, the group of the Academy of Nutrition, Alison Steiber, who conceived the guideline, the team from the National Kidney Foundation, and this amazing work group member who worked very hard for us to have the guideline released. Thank you very much for your attention.
Thank you very much, Professor Cuppari, for this elegant and timely lecture. I would like to remind that participating to this working group seminar, you can earn 1 European credit for your professional and educational development as an exclusive benefit from this ERA EDTA initiative. So we have now time for enough time for a nice discussion. Remember that we have 3 panelists as well, and as a moderator, I would like to start. So far, we don't have many questions. Please do not hesitate to to ask questions. The first one would be, this is something very general for Professor Cuppari. What do you think the best frequency of diet survey at different stage of CKD? This is a very important question. Of course, it's linked to reimbursement in some countries. So what do you suggest, for example, a stage 4 or 5 pre-dialysis CKD? What is the optimal dietary survey of these patients?
Thank you, Dr. Fouque. It's not easy to answer this question because it depends on the patient clinical status. But in general, I think in the beginning, when you first prescribe a diet that is a diet low in protein that we are recommending, the first month, I think once a month, in the first at least 2 months, I think it's important to assess dietary intake, to assess nutritional status with the parameters you have available. And then if everything goes well, I think every 3 months, I think it's my view in my clinical practice. I'm not sure if everybody agrees with me.
Professor Bellizzi, what is your traditional frequency in these patients?
I agree, there is not a precise timing. In my opinion, the main point is of course, the degree of CKD of the patient, and if the patient is has a progressive CKD or not. In this case, things may change rapidly. In general, CKD patient on stage 3 to 5, I see them every 3 months. And stable patient have to, in my clinic, have to be evaluated from a nutrition point of view every 3 months. And patient with more advanced CKD can be evaluated more frequently. We also used to prescribe the very low potent diet. In this case, the nutritional assessment is it's more frequent, and we see the patient at each visit that is around 4 to 6 weeks, so quite often. I know that there is not a precise timing, but this is what we do. But if I can, I would make a comment and also ask a question, because for instance, we do not have many dietitians in Italy, but I think it's the same for Europe, for the whole Europe. So there are some parameters which are, of course, critical. One of this is the energy intake. When we do not have dietitian, how, this is a question, we could measure the energy intake. It is very important mainly for subjects who are in a very low potent diet. And so when we do not have a dietitian, do you believe the nephrologist enough skilled to perform a food frequency questionnaire or an interview to exactly define the intake of energy, which is, in my opinion, is as much important as protein.
And what do you think about Sweden and Spain? Because with Professor Carrero, it's easy, we get 2 countries.
Well, I think that we have the same limitations in Sweden and in Spain. There are few renal dietitians, and I suppose that in many practices, the work is left for the nephrologist, which maybe doesn't have the time, doesn't have the expertise, or doesn't have the possibilities to do a thorough assessment. Simplicity, I suppose, would be key. But some of the tools emphasized by the guidelines, I think, that are simple enough for many people to implement. And assessment is important, but maybe more important than assessment is the screening. And a screening is so easy that can be implemented almost on every visit. It's just a checking of 4 questions about appetite, recent weight, problems of intake, and that can give you an initial step to refer, if you have the luxury, some patients to the dietitian or the nutritionist. I think we can do it if we take it more seriously.
Okay, we have a question now for Dr. Avesani. In practice, this is a question from Dr. Naidin. In practice, what tool do you recommend for CKD patients to estimate their daily protein intake?
Okay, thank you. Okay, I think we should combine. First, I believe very much in the food questionnaires. So an estimation of the food intake by asking the patient their usual protein intake, it's very helpful. It can be done from the last 2 weeks, and combined also with a 24-hour food record if the day before was representative of what the patient normally eats. If there is the possibility of the NPNA, because if the patient is on pre-dialysis, there is the need of the measurement of nitrogen excretion in the urea. But if this is possible, it's also complementary. But I think it's important that we keep our eyes not only in the amount of protein, but in the source, in the quality of the protein. So to evaluate whether the patient has a source of protein from vegetable and from animal, and if it is from animal protein, whether it is fresh food prepared at home, or if it is protein coming from ham, from ultra-processed food like sausages, that in addition to the protein carries also with itself sodium. So I believe there is no easy recipe, but we should combine different methods to assess food intake from food questionnaires, and also, if possible, NPNA, and look mainly not only in the amount, but also in the quality. That's my view.
Thank you. We have a short question from Dr. Jamal. Should we stop prescribing folic acid to all CKD patients? Maybe Juan Jesus?
Well, the guidelines made it clear that they don't see the point of routine supplementation of folic acid. So maybe what we need to wonder is whether the prescription of folic acid in your patient is justified or still needed. I think maybe revisiting the aspects would be important.
Thank you. We have a question from Dr. Bowick from India. Generic question, not so easy. What is the role of frailty assessment? And is this relevant to assess frailty? Maybe Professor Cuppari. You should unmute.
Okay. Yes, I don't have much experiencing in the parameters to assess fragility. But for example, for sarcopenia, that is associated with fragility, it's important to pay attention in loss of muscle mass, using some methods, for example, hand grip strength. I'm not familiar with evaluating fragility in my clinical practice. And I think, if I'm not mistaken, there is no information in the guideline about this. I think Juan can ask this question better than I do.
So, we did not evaluate frailty because there are more than 100 different definitions and algorithms and scores in the literature, and the majority of them maybe have not been validated. The ones that are used are very interesting from a research point of view, but maybe a bit complicated to implement in clinical practice. At the end of the day, assessment of frailty is focused on assessing muscle mass and muscle strength. So if those are the two main components, then the guidelines already provide feedback about which methods could be more useful in assessing these two aspects of musculoskeletal health. That would be hand grip strength and then body composition with different measures to assess muscle mass.
Thank you. We have now a couple of questions on keto analogs, low protein products, but before entering this important field, we have a generic question, I think important from Dr. Kletzmeier, on the weight management. Maybe for Carla, weight management is not covered in the guideline, but it's a very important topic in clinical practice. For example, weight loss before transplantation. What is your opinion, and is there a guideline to be expected on that?
Well, as we say, very interesting question when you don't have a very clear answer. But I believe that the loss of the continual loss of body weight should be valued regardless of the stage, whether it is on CKD stage 3 to 5 or dialysis or pre-transplantation. If the patient is losing body weight over time, it is an important sign indicative of risk for malnutrition, even if the patient was someone obese who is losing body weight and to become underweight. So I believe that this should be valued. The same should be valued on the other way around. I believe serum measurements is the key here. If the patient is gaining body weight, also should be valued, because obesity is also not good. Although this is a very controversial subject. But I don't know about the guidelines. As Lilian said, the guideline is a live document, so it will be updated over time. But if someone would like to compliment me.
But if I may add, I think that nutritional management of patients on the wait list, and especially nutritional management of people on transplant, it's something that guidelines have neglected most of the time. I think there is a guideline from Australia that was done a few years ago, and because of space and economical reasons, the KDOQI and KF could not enroll this type of evidence. We think it's important, and from the European Renal Nutrition Working Group, we are now working on a summary document opinion, because we don't have budget to do an evidence-based analysis on how to manage patients on the transplant list and during the after transplantation. So I hope this would help recognizing that malnutrition is also important and frequent after kidney transplantation, and maybe not so much taken care of.
So we have now a couple of questions on low protein diets, and maybe I would like to ask Dr. Bellizzi. We have basically two types of topics. The first one is from Dr. Triolo, possibly in Italy. What is your opinion of the use of hypoproteic commercial foods? First, and then from Dr. Sharma, what is the role of keto analogs in the current era? Should we use them in all patients, or are they helpful only in a subset of patients? Vincenzo.
Yes, thanks, Denis. This is a very important topic. Let me first say that maybe one of the major difference between these guidelines and the previous guidelines is are the statement on the amount of protein. Previous only a limited number of patients. There were recommendations to prescribe the low protein diet only to a limited number of patients. Now the low protein diet have no restriction, so all the patients may, if they are considered stable, may receive a low protein diet, and also with high grade of evidence. And also the very low protein diet is allowed for some selected patients. So one difference with the past that now the low protein diet is an opportunity for a large number of patients, as a difference with the past. The keto analogs are used only when is prescribed a very low protein diet, and the rationale is to provide the minimal amount of nitrogen for the protein synthesis. Since the 0.3 to 0.4 is under this threshold, we have to add the keto analogs. In other circumstances are not indicated the keto analogs. And maybe the question of the on the aprotein food is maybe related to this point. This is a further option. The aprotein food have two major characteristics. One is that they do not have protein. The other one is that they provide energy. So there are evidence, and this is also my opinion, that this is an additional advantage to have a protein food. You can provide the energy the patient needs while reducing the protein intake. And if available, they could be used in every kind of low protein diet, not only very low, but also low protein diet.
Thank you. Does anyone wants to add something?
Well, I think there is a question that maybe is more for you, Denis, from Lina Johansson. So does the panel have any comments about the difference in conclusions from the protein section for non-diabetes CKD patients from KDOQI and the recent reviews that have suggested otherwise, in particularly with mortality and progression to SKD?
Thank you, Juan Jesus. I wanted to avoid this question, but now I have to clearly answer it. Thank you, Lina. In fact, this is a technical issue because these two documents, one is the KDOQI guideline we speak today of, and the second is a review published 6 months ago. And the conclusion is slightly different, but in fact, the methodology is not the same. One analysis took only all studies with low protein diets, and the other one took all studies with keto analogs only. And as a consequence, the same studies have not been selected in the same analysis, and the conclusion is slightly different because we are not speaking of the same studies. In fact, the selection is different and the results are different. That's the reason why we see these discrepancies between the two works that have been published at the same time. And fortunately, I've been a member of both works. That's why I can really ensure that, obviously, if you compare two different criteria, you may not have the same results. And that's the reason. We have also a number of other question. I just wanted to add with what Professor Bellizzi mentioned about the use of apoprotein tools and foods. We are now using them largely in France, and it is quite convenient to help patients to rapidly reduce their protein intake without much dietary changes. And I think this is important because you can really reduce by 0.2, 0.3 kilogram per day protein just by switching bread and pasta in your regular diet. And very rapidly you reduce by 0.25 gram protein per kilogram per day, which is a very easy way to start this low protein approach. Sometimes people is afraid of reaching such diets, but in fact, in our experience in Lyon, it's really something rapidly feasible, granted that the patient can meet the dietitian 2 or 3 times to really be taught and accustomed to the food selection process. But this low protein food allows some patients to rapidly get their lower protein intake. Does everyone agree with that?
May I have a comment about this? It's interesting because it depends on the food habit of the population. For example, in Italy, pasta is something that is much eaten. So, and here in Brazil, I have experience with keto analogs. And here our main food habit is rice and beans. So we know that beans has proteins, but it's a vegetable protein. So what we have done with these patients, and we allow them to eat rice and beans. We sometimes reduce a little bit the amount of beans, and all the other vegetables and food made with flour, like bread, they eat normally. So, and we have had very good results with a decrease in protein intake. It's almost a vegetable diet, vegetarian diet, for example. And I think these products are interesting for patients with these food habits, with pasta and a great amount of bread, for example. That's my comment here, my experience.
Carla, you have something to add? Oh, you're on mute.
I'm sorry. Well, I'd like to complement something similar to what Lilian said, is that my clinical experience was in Brazil more than in Sweden. And in Brazil, we don't have access to this non-protein food. But I believe that as in Brazil, as the same as in other countries, we have some food that are low in protein and a great source of carbohydrates. As example, manioc in Brazil, that it's a quite common food that we found from north to south, east to west. And I encourage dietitians and nephrologists trying to look to these alternatives as well, because sometimes they are more feasible than this food that are modified to have least amount of protein.
Okay, we have a lot of remaining questions. One about the role of megestrol to improve appetite in CKD patients. Maybe Juan Jesus?
Sure, I can answer that. So yes, there are about 10 or 11 interventional studies on megestrol acetate in the literature. To the best of my knowledge, only one of them is a randomized controlled trial. It didn't make it into the literature review because there were many other questions to prioritize. The studies are in general of low sample size and low duration, but they show that megestrol acetate may be effective in improving the appetite at the beginning. It's not a long-term therapy. It's something that you would initiate maybe for a month, 2 months, and if the patient starts eating, then you can stop the therapy and it will go by itself. Be aware only of potential adverse effects like volume overload, because it retains liquid, or increase in ACTH levels. But there are minor things that can be solved with monitoring.
Thank you very much. We have time for a last question, and this is for Professor Sharma. Any comments on the source of proteins, animal versus plant, vis-a-vis phosphorus potassium level, particularly in dialysis patients? I think everybody can answer that. So maybe Carla.
Okay. Well, the evidence that we have from the last 4-5 years encourage us to support diets such as the Mediterranean diets or the DASH diets that have a great deal of more vegetable food intake, vegetable sources than the protein sources. And we, together with Juan, we made a review about the potential of vegetarian diets, plant-based diet, which is different from vegan diets. But the plant-based diets, they offer many benefits for patients with CKD, like vitamins, minerals, micronutrients. They should be very careful, monitored regarding the potassium levels, but it doesn't mean that it should be restricted, it should be adjusted. And the protein sources that are from vegetables, they offer lower amount of urea, so they are a good help to control for the progression of chronic kidney disease. That's my view.
Juan Jesus, you want to add something?
Yes, well, at the time, I remember we discussed this, you and I, a lot when we were doing the comments of the guidelines. At the time of review, there was not much evidence or not many studies enough to do a statement about the quality of the protein. But now in the recent years, especially, there was a very nice paper in NDT a couple of months ago, looking at the differential effects of protein from plants versus protein from meats in the long-term risk. And I think it's something that maybe we should consider, not only because of the amino acid profile in itself, but also because all the nutrients that come along with protein from plants versus protein from meats. We would have less bioavailable phosphorus, we will have more vitamins, we will have more minerals, all the aspects that Carla has been mentioning. This can also function for dialysis patients, and I take it that in societies like in India, a large proportion of dialysis patients will be vegetarian or vegan, and maybe we should learn from those societies, because much of this can be translated here in Europe. It's not incompatible, a plant-based diet in patients on dialysis, and maybe our fears for hyperkalemia should be toned down, because at the moment, the evidence that we have that diet is the main determinant of potassium levels in our dialysis patients is probably very low. There are many other things that prompt hyperkalemia in our patients, and probably more importantly than diet.
Thank you very much. So before we leave, I have an announcement for everyone. You will receive a short feedback survey to take no more than 2 minutes to provide us with useful information and to improve the next meetings. And do not miss the next e-seminar, How to Limit Vascular Calcification and Treat Calciphylaxis, organized by the CKD and BD Working Group and scheduled in 2 weeks on February 18. By this, and despite a lot of remaining questions, I would like to thank everyone for this elegant lecture first, and also very enriching discussion. And with that, thank you very much and wish you a nice evening. Bye-bye.